Good luck. Good afternoon, everybody. Thank you for joining us today. We will just wait for 5 minutes and waiting everyone to join us on the webinar. We'll just get started in a few minutes' time. Everyone will be placed on mute as you join our webinar, but you'll have lots of opportunities to ask questions using the Q&A function. If we go to our next slide, we'll put some little tips on how to have a successful webinar. So please do use the Q&A function throughout to ask your questions. And let us know who we have on our webinar today. We'd love to know who you are, where you're from, and key things you'd love to learn about today. Our webinar will be recorded and will be made available to everyone who has signed up. We're nearly ready to start. 1 more minute and then we'll be underway. Fantastic. We're going to start now. I'm going to hand over to our chair, Andrew Cuff.
Good afternoon. I hope you can all hear me. Welcome to this second webinar in our Connect Health Change series. This webinar series is designed to focus on hot topics affecting NHS clinical delivery, particularly those that represent periods where change is either happening or is coming further down the pipeline. The first in this series focused on making and embedding transformation post-COVID, whilst today we'll be discussing the successful and sustainable implementation of FCP within primary care networks. The inspiration behind focusing on this topic has been twofold. In a pre-COVID world, FCP has been a hot topic for a number of years, gathering momentum throughout 2019 and increasing speed developing into the early 2020. Conversations were happening with PCNs as they looked to utilise their additional role reimbursement, and pilots were coming to an end. But like many things, COVID put a stop to this. As we entered into phase 2 COVID recovery around about July, we were starting to see that the momentum around FCP implementation was picking up again. And part of the driver around this was due to the timeline associated with the DES for FCP, particularly the DES for FCP within PCNs, and partly due to the potential that FCP was seen to have in supporting COVID recovery and the elective backlog. Within Connect Health, as being a national provider, it was clear there were lots of conversations ongoing, with similar discussions, similar challenges and similar questions occurring. And to this end, we thought exploring some of these questions and challenges to and with a wider audience would be of value. And it brings us to where we are here today. So we can get the next slide for the agenda, please, Paul. So as you can see, we have a fantastic panel of speakers that will provide a 360-degree view of FCP. We have representation from the Chartered Society of Physiotherapy, Health Education England, a GP, clinical director and former commissioner, an ICS leader, as well as representation from an existing MSK provider. As a reminder, please use the Q&A function to ask any questions. Each talk will be 7 minutes in duration, and there will be 3 minutes afterwards for a brief Q&A before the next speaker. There'll be a longer Q&A at the end, but without further ado, I'd like to hand over to Amanda Henson-Cook, who is a consultant MSK physiotherapist and is a Health Education England AHP clinical fellow, who will be talking us through a primary care practitioner's roadmap to practice. Thank you.
Sorry, my bad. Always start with a mute. So can I have the first slide, please? Hi, everybody. So I think it's always best to start from the very beginning to explain where FCP sits in terms of the Advanced in Practice pathway, because as you'll be aware, in the new roles coming into primary care, you have FCPs that are at band 7 and band 8A, so it'd be quite good to explain where that sits. So in the world of the Advanced in Practice agenda in Health Education England, you have an enhanced level of practice, advanced level practice, and that moves into consultant level of practice. Where the band 7 FCPs sit are in the overlap between enhanced and advanced. And the reason for that I'll explain in a second. As you know, there's 4 pillars of practice. You've got clinical, education, leadership and research. And when you're an advanced practitioner, you're expected to be working at level 7 across all 4 of those pillars. Now, FCPs, as an entry grade into primary care at band 7, although you have an advanced level of practice in the clinical pillar, i.e. you're working at level 7 master's level, you haven't necessarily yet gained sign-off to level 7 across the clinical, education and research pillars. Next slide, please. Thank you. So it might be just worth looking at what the pathway is. The reason we started doing a pathway into primary care right from the very beginning is so that people have a clear roadmap if they want to move into primary care, what they need to do to get there. So you have your pre-registration degree, which can either be 3 or 4 years, and you come out and you go into the real world of physiotherapy, and then you do 3 years of working as a minimum before you start your primary care training. Ideally, you should be doing 3 years in MSK to do this. so that you are used to working within MSK and you know your superpower. So once you've done that, you can start doing primary care training. There's two ways to do this. You have a portfolio route, which I'll explain shortly, or you can go and do a level 7 FCP module. Now the curriculum, if you like, which is probably the wrong word to use, but the content of the FCP course is exactly the same as the portfolio route. The difference between the two is that all of the portfolio route sits within the module, and when you do the module, you come out with a level 7 points from the university that can be used if you wanted to go on to do an advanced clinical practice master's degree. You've got some master's points to take with you. The portfolio route, you won't have an accreditation at the end of it, but you will be recognised as working at level 7 as a first contact practitioner. Next slide, please. So this might look really complicated. This is the whole thing. So this is the whole roadmap for FCP to AP on the left-hand side of the screen. And on the right-hand side of the screen is what happens if you're an advanced clinical practitioner and you've done a master's degree in that, and then you want to work in primary care. So I'm going to focus to begin with on the left-hand side of the screen. And in the next slide, we'll go into it in a little bit more detail, so bear with me. So the stage 1 part of it is about developing the knowledge part, your academic knowledge around MSK, making sure that you're working at level 7 in your MSK Masters level 7 world, and you're also learning your primary care skills. So this is the knowledge part of the academic knowledge part. So like I said before, if we just leave the module side because it has all the same things in it already, in the portfolio route, you do the knowledge, skills and attributes training, the academic side, before you go into primary care. Then once you're in primary care, you're then going on to making sure that that knowledge is applied to your practice. And I'll explain that a little bit more carefully afterwards. And then once that has happened, you can go on to moving on to advanced practice via a portfolio route after that, if you want to. And the reason for that is what's really good about it is that you've already got your clinical pillars signed off to level 7, and it isn't in an isolation with the knowledge, skills and attributes. You've also completed a lot of the domains of the other 3 areas of practice, but you haven't quite managed to get to level 7 across all of them. So there's just a top up that's very, very clear in the roadmap document that's coming out that will be able to tell you how to do that and what support's needed to do that. If you're an advanced practitioner already, obviously it's really important to make sure you've got primary care training as well. So it will be expected that if you have done an ACP course, that there's evidence around the primary care training as well. So the knowledge, skills and attributes are also relevant to the people that have already done ACP master's degrees. Next slide, please. So just focusing on the FCP bit, just to be really clear, so you've got the stage 1 and stage 2. So the stage 1 is your primary care specific training in your MSK knowledge, skills and attributes training. The knowledge, skills and attributes come from the IFOMP standards and the MSK core capability standards. The IFOMP standards are our international physiotherapy standards that are the agreed national standard for MSK now in the UK. So those 2 things together, plus the primary care specific training, all come under the academic part in the first part of the training. Then you move into practice, and then you do stage 2, where you get signed off against the RCGP workplace-based assessment by your supervisor to make sure that you're putting that knowledge into practice. And the final slide, please. So obviously it's really important that you have support through this. So in terms of supervision, Health Education England put in a national strategy, which is a 2-day course via the training hubs, that on the day 1 it will be about working as what CPD supervision, clinical supervision is, and how you work with the multi-professional team, because as an advanced practitioner you can look after the whole multi-professional team. And on the session 2 it's about that workplace-based assessment and how to use it to be able to help verify the practitioner to first contact. Once you've got the verification for the first contact, you're recognised and you'll be kept at the Centre of Advancing Practice in Health Education England. There'll be a first contact directory so that you go onto that, so you're recognised as already as part of the Advanced Practice Pathway. So I think that's my 7 minutes. Any questions?
Thank you, Amanda. I don't know if you can hear me okay. There's been a few questions from the chat, and I'm gonna answer those that have had the most likes. So for those watching the webinar, if you see a question that you agree with, you'll see that there's a thumbs up button next question. So if you want me to answer the question, then vote it up and I'll answer it. If not, I'll just pick and choose. So there seems to be a few questions on a similar theme around why the minimum 3 years in practice prior to starting the stage 1 competencies, as opposed to just being competent. So if you had somebody who was 2 years qualified, but you thought could do the job and can demonstrate stage 1's competence, can they enter into the roadmap?
No, so what it is, it's when you're in primary care, it's a very different environment to community care or acute care, and it's working in primary care is not something that you can do just from graduation. So it's really important you learn your craft first, and the really important part is about complex clinical decision making. That is something that you can learn academically, but actually in real life you can't actually do that until you're exposed into the workforce and you're putting that knowledge into practice. So that's why the minimum's been set at 3 years, and it should really be working in MSK for 3 years to do that. You're working very much at the very top of your scope of practice. So you're expected in primary care in a first contact role. You are a diagnostic clinician who works with undifferentiated diagnosis from reception, and you need to be able to differentially diagnose, which has that the complexity around it. And it's not just about the MSK, it's about non-MSK and how that feeds into it. It's about environmental factors, it's about safeguarding, it's about mental health, and it's about knowing the whole system. You've got to understand the whole NHS system to know where to refer properly through if you're triaging out to other services.
Brilliant, thank you, Amanda. We've still got a couple of minutes. I just want to follow up that question if I can. So with regard to the P in FCP, naturally at the moment we're thinking around first contact physiotherapy. Is there scope for this to be, this first contact practitioner framework to be multi-professional? And I suppose my thought process there being, if you have a chiropractor who has 3 years working with MSK, or a sports therapist that has 3 years working with MSK, can they enter into this route if they can demonstrate their stage 1 competence?
Okay, so going for the multi-professional thing, we can't use FCP with the peers physiotherapy really, not only for MSK, but if you imagine we've also got first contact paramedics coming in and first contact podiatrists coming in, it's all going to get a bit confusing with the P's. So I think it's first contact practitioner, just to make that clear to begin with, otherwise it could be all over the place. But in terms of MSK, the way that we've written the roadmap is for the multi-professional MSK team to be able to do that. So in terms of other MSK professions, absolutely yes, they can do this, but you'll find that with the knowledge, skills and attributes documentation, with it has to be triangulated evidence. It's not a tick box exercise, this. It's triangulated evidence with a minimum of 2 pieces of evidence to sign off each domain. So it will be people that are not quite ready to do the job role, whichever MSK place they come to. It's going to take them a number of years to be able to do that if they're lacking in some areas of practice, which also goes back to why can't people do that straight away if they want to? Why 3 years? Because you simply haven't got that breadth of knowledge and depth of knowledge to be able to sign off in triangulated evidence against a roadmap. It's a real safeguard against people coming in unqualified and untrained into fact, but it doesn't stop anyone from doing it, for sure. If you're able to do that, then there's no reason why you can't be sitting in that role.
Brilliant, thank you, Amanda. It's mindful of time, but I have a feeling that when we get to the Q&A at the end, there might be a few more questions regarding that, but we can pick that up in due course. Fantastic, thank you. So I'm going to move us on now to introduce Larry Koyama, who is the head of FCP implementation at the Chartered Society of Physiotherapy. And Larry's going to update us on the CSP's approach and learning for sustainable implementation of FCP. So over to you, Larry.
Thanks, Andrew. So I guess it's useful to start to just say this is a topic that can take a fairly long period of time, but we've got 6 or 7 minutes, so I'll try and be as brief as possible. Next slide, please. And the one after that. So as a start, I think it's really important to recognise, firstly, that from the CSP's perspective, FCP remains a really significant strategic priority. And along with that being a strategic priority, there's obviously the resources that are allocated to support that, along with community rehab and workforce development over the next 2 to 3 years. Our approach to effective implementation of FCP firstly spans UK-wide, so the remit within the CSP is not just about England. I appreciate the conversation today will be very much around England, but I think there's also lots of learning to be had from Northern Ireland, Scotland and Wales in terms of their approach to FCP and some of the challenges that they've had to overcome, which are slightly different to ones that we have. In terms of our approach internally though, so we have 4 key work streams around effective implementation and supporting the rollout of the first contact practitioner role. The first is really around national influencing. So that is essentially me and Sue Haywards-Giles having that national strategic influencing role with the key stakeholders, whether that be at NHS England or Health Education England. So working closely with Amanda, making sure that the commitment to the rollout of FCPs remains at a national level, but also ensuring that that rollout is done in a way that's sustainable, both in terms of clinical practice, but also in the best interest of the members who are doing that work. The other work stream we have is local influencing. So this is around really understanding that whilst there is a national strategic direction, there are also specific challenges both in local areas, regions and countries. And therefore being able to kind of build and understand the key stakeholders within that and the unique challenges that they're having. So in some places, those challenges might be around workforce, for example. In other areas, it might be things like London waiting, which I know you'll probably come on to a little bit later. In places like Northern Ireland, it'll be more around training places. So there are lots of different strategic challenges that we have. So it's really important we understand the local context and therefore, as an organisation, be able to support those key players within that. And sometimes that actually includes working with our NHSE regional colleagues and as well as our HEE regional colleagues to really take that, as Andrew talked about, 360 perspective in terms of implementing this model of care, which is new and therefore has its challenges. The third stream is around really empowering our profession, so empowering the members within our profession to take on these roles, be ready to do these roles, but also be able to implement them effectively. And part of that starts with internally making sure our professional advisors are able to support our members to implement and embed FCP roles within healthcare systems across the UK. That requires a significant amount of knowledge and understanding of those roles, but also some kind of external consultancy type work with members who require that help, whether that is at a regional level or specific challenges around conversations with PCNs or influencing at a wider scale. The final piece of the work stream is around evidence and data. So one of the core things about the FCP model, despite some of the sort of queries and challenges we get, is the need for FCP roles is embedded in evidence. It's embedded in evidence, broadly speaking, around the roles multidisciplinary teams have in primary care. It's embedded in the evidence around the importance of primary care for any high-performing health system. And it's also embedded in some of the evidence that is growing constantly around the impact that they can have. So some of that work has included, for example, the phase 1 and 2 evaluation. We've just actually had the phase 3 evaluation report come in recently, which is going to give us some real key lessons around what the lessons are for effective implementation. And we'll be hopefully launching that on the 30th of September through a webinar. Underpinning all of that we've just talked about, you have the comms and influencing aspects. So that's clearly really important. So that's how do we communicate some of these approaches externally to our stakeholders, the BMA, the RCGP, the PCN directors, but also how do we communicate that to our members to make sure that they're getting the right information, but also they're feeding in to make sure that we are on the right lines. And finally, workforce underpins all of this, and that links in quite close to some of the work that Amanda's talking about as well. So making sure we have the workforce which is robust to do the work effectively and do it justice, but also agile enough to meet the demand that is there within national priorities. Next slide, please. And so it's really difficult to pinpoint exact specific things that are integral and will support implementation, but I think there are some core things that come through in all the conversations and all the lessons that we're learning. The first is systems leadership and thinking. That is fundamental to understanding the effective rollout of these roles, particularly when it comes to things like recruitment models or employment models, when it comes to systems taking that strategic view about how they plan their workforce. We're finding often, and understandably, some PCNs will be in slightly different stages in terms of maturity and the conversations that they're able to have. And so some decisions might be made with specific things in mind rather than the wider system. And so those systems leaders are a really important part of supporting effective implementation, particularly in England, where we've got more of a free market economy compared to the other countries in the UK, which is much more centralised in terms of the delivery of their health system. The other really important thing which is linked into that is around population health. So this is really understanding the value of population health, but also the skill sets to be able to work in a population health management approach. And again, part of this is to have FCPs and system leaders understand the needs of their population and be able to decide what their workforce plans are. So MSK being a key issue for primary care, and therefore being able to identify how many FCPs they need, for example, and how best to get those FCPs to deliver the services that they need. Integrated systems and processes are really important, and you know, one of the conversations we've all had, I'm sure, is around the importance of not having siloed working with FCPs or any additional roles, so that follow through from primary care all the way to secondary care, but also into the community is really important. And it's important that both the way we think is integrated and the approaches and the way people work is integrated, but also the systems and processes that we have, whether that be IT or referral pathways, is completely integrated with the patient in mind all the time. We're learning that the role of our clinical colleagues, our GPs and PCN clinical directors, is really important, both as champions for the roles, but also in terms of being able to work effectively with FCPs who are new to primary care or working in primary care. That relationship is quite a crucial one for success in the long term of these roles. And embeddedness and integration is also really important. So that comes down to your FCPs. There has to be a certain amount of integration with the wider health system, but it also has to be something about them being part of the primary care team. And I think sometimes when we have these conversations, we seem to forget a little bit that these roles initially emerge because of the need to support primary care. And that's a really important concept as we move forward, that these roles are there to support primary care. And as part of supporting primary care, they also need to be integrated and linked so that the benefit to patients are maintained, but they're not there to support secondary care and then primary care be at the end of that. These are primary care roles to support that wider multidisciplinary team, and therefore these FCPs should ideally be part of that team. So having conversations generally, being part of meetings, being part of general plannings, and being seen as equal members within the primary care team and workforce. The other significant criteria, which I think is linked into some of the things we've talked about in the top there, is around workforce. So workforce is a really important barrier, but there's also opportunities to think flexibly around how we can get the workforce to be trained and have the skill sets, but also to be agile and to think of that. So if we don't have sufficient or adequate workforce planning or resources or methodologies to kind of reduce the workforce challenges, then it can hamper the success of these roles in primary care. I think that's it from me, Andrew.
Brilliant, thanks, Larry. I'm just mindful of time, and I've seen the question from Martin Billing, which has got a number of likes, but I think that's probably a good question for Larry to kick us off in the open Q&A. But I suspect a few people on the panel have a perspective on it, so I've seen it, and I'll pick that one up at the end, Martin, if that's okay. In the premise of time, I'm going to move straight on to John Toes. So John is a GP by background. He's formerly a clinical director based up in the northeast of England and the South Tyneside CCG, but is presenting today from Manchester. And he will describe his experience of introducing FCP into a primary care network in South Tyneside. So I'm just going to hand over to John now.
Hi everyone, and thanks Andrew. Yes, as Andrew says, I spent most of my working life up in South Tyneside as a GP and as a CCG clinical director, but I'm now a GP in Manchester. And I'm briefly just going to tell you about what my views are about implementing FCPs into a PCN and our experience that we had of that up in South Tyneside. So a little bit of background about South Tyneside. It's a relatively small CCG, 150,000 population with 3 PCNs, each of about 50,000 residents, with about 7 practices in each PCN. And I come into the story as the GP commissioner responsible for supporting primary care. But when I heard about FCPs as part of the additional roles reimbursement schemes that PCNs could recruit to support their teams, I was really excited. Next slide, please. However, when I raised the discussion with the 3 PCN CDs, this was the response I got: not more physiotherapy. And I think this is a really important point, that not everyone, certainly at the time that we had this discussion, really understood what an FCP actually was. And the CDs, who should know more than anyone what the role involved, thought it was about more physiotherapists working maybe out of hospital or out of the community services and into practices. And South Tyneside already had a well-established community physiotherapy service that had self-referral and a physio line, a telephone service, as well as an MSK CAT service that was a kind of slightly more advanced service that was sitting part way between primary care and secondary care. And so this was the response we got: well, why do we need any more? And that was also the response we got when we started to talk to practice managers and practice reception staff, that they didn't quite get it. So one of the key messages is there needs to be a lot of work in engaging with the practice staff, not just the CDs, but also the patient. So use your social media, patient reference groups, etc., to help people understand who this new person or these new people are who are working with the GP teams. Next slide, please. One of the practice managers is actually a physiotherapist by background. And before we started a 6-month pilot of introducing one whole-time equivalent FCP into one of our 3 PCNs, that practice manager wondered what kind of impact this would have. And he reviewed a series of requests for GP appointments to his practice. And he determined that if he was the FCP, and he's a fairly senior physiotherapist by background, he thought that 21% of all of the requests could be dealt with by the FCP rather than seeing the GP. And I think this was the thing that persuaded the GPs to get on board with this. They saw that potentially 1 in 5 of their requests could be dealt with by somebody else. So as I said, the pilot ran for 6 months. We've got 5 months worth of data on the left-hand side, and the font's pretty small, so I'll just generally explain what it tells us. Well, first of all, each month that we ran the pilot, the numbers of direct referrals into the FCP increased. I hesitated when I used the word referral. These appointments came directly from reception, or potentially could come directly from online booking. So these weren't referrals from GP appointments, so they bypassed the GP. And to build on Amanda's point, that means you've got undifferentiated problems coming to see the FCP. The vast majority, well, certainly just over 50% of all of the patients that the FCP saw were dealt with an assessment and an explanation, followed by a management plan for that person to follow. About 25%, and that's the orange you can see there, were referred on to other MSK-related services, whether that be MSK caps or physiotherapy, and smaller amounts were sent to specialties such as podiatry. In total, only 3 patients were referred to secondary care, all of whom were referred to orthopedics, and all 3 ended up on waiting lists for surgery. So that 100% conversion rate is something that's quite unusual. I think the GPs have about a 30% conversion rate. And finally, well, what do people think about the service overall? And this quote on the bottom right-hand corner is from one of the GPs. We certainly felt there was a lot of value in this. And I'm going to end there.
Brilliant. Thank you much for that, John. You seem to have had a successful pilot that has moved towards implementation stage. What do you think, or what, in terms of your experience, have been the key ingredients for successful implementation up in South Tyneside?
I think it really has to be understanding what the role is, and then we were lucky enough to have 2 experienced physiotherapists who were going to share this role, and there was a lot of relationship building that had to take place, I think, before it started, not just with the PCN CDs, as I explained earlier, but with the other members of the practices. As it happened, the 2 practitioners ended up working in just one practice, seeing patients from the whole PCN, but just from one practice. And I guess that was great for that practice. And in fact, most of those patients that are represented in that bar chart came from that practice, which actually means that the rest of the PCN missed out. Now, I haven't got a solution to that, but I guess one thing that we should think about is how do these limited number of people work across 4, 5, 6, 7 or 8 practices within a PCN and maintain those relationships and offer a sort of fair and equitable service to all the residents in the PCN.
That's brilliant. Thank you, John. And just one more question before we pass on to Catherine. There's a couple of questions in the Q&A which I'm going to link together. The first one being, is the FCP approach going to work long term, or do we see it as a forced dawn? And of the 21% of patients, how many could have been dealt with by the existing Tier 1 and Tier 2 MSK service?
That is a very good question. Okay, so the first one, I certainly think FCPs are here to stay. I would love to see them grow, and I would love to see a significant number of FCPs working in each PCN for lots of reasons. I think if 1 in 5 consultations can be dealt with by an FCP, then we're going to need a lot of them. But also for the sense of being part of a team, we need a lot of them. If it's just 1 or 2, they're going to feel quite isolated. The second question is, well, what proportion could have been seen and dealt with directly by the Tier 1 and Tier 2? That's a difficult one, I think. A lot of the patients were referred from the FCP into Tier 1 and a smaller number into Tier 2. I think it's a different role, really. The patients who are self-referring into Tier 1, it's a guided self-referral. They've usually seen the GP first, so it's not a completely undifferentiated problem. I suspect coming back to the first part of the presentation, I suspect the training and the experience of the practitioners working in Tier 1 is not as high as the FCP, so they may struggle with some of the undifferentiated problems.
Brilliant, thank you, John. I'm going to move us on there. I think there's a few questions in the Q&A which we can pick up at the end. I'm now a pleasure to introduce Catherine Thompson. So Catherine is the Programme Director for Improving Planned Care within West Yorkshire and Harrogate Health and Care Partnership. And Catherine's going to talk about the local success in improving FCP provision within the integrated care system and across the wider MSK pathway. So over to you, Catherine.
Thank you, Andrew. So yes, I'm Catherine Thompson. I'm a manager now, but I am a physiotherapy by background, a physiotherapist by background, although not of the MSK variety, it has to be said. So I think I should start by saying that I can't take the credit for what I'm going to tell you about. I supported the work, I facilitated it, and I brought everybody together. But the people who did the hard work are my colleagues in each of the places of West Yorkshire and Harrogate who made this happen by creating the roles and getting it all off the ground. So I am the facilitator and telling you about it, but I didn't do it all by myself. As part of my programme of planned care work, we'd been asked to redesign the MSK pathway and align it across the whole of West Yorkshire and Harrogate. So not that the services would be exactly the same, but they would contain the same core components and the experience of care and the standard of care and what was on offer to a person with an MSK condition would be the same across all places of West Yorkshire and Harrogate. And we'd all agreed that we should have first contact practitioners at the front end of that pathway. So we merrily got on with that, agreed the pathway, and that is now the agreed commissioned pathway. And we held an event for the whole of West Yorkshire and Harrogate to explore how could we make this happen. And Larry's predecessor, someone called Sarah Withers, came up and did that event with us. And it was really great to really just generate the enthusiasm, see the enthusiasm and get the ideas for how to make it happen. We were really fortunate that both Leeds and Harrogate places were part of the CSP pilot. So we had some kind of early start. We weren't starting from an absolute zero. So we had some FCP posts in place in Leeds and Harrogate already. But what we needed to do was to get that spread across the whole of our ICS footprint and to make it sustainable. We didn't want this to be a kind of flash in the pan thing that seemed like a good idea at the time but never really survived. So an opportunity came to bid for some funding from our local Workforce Action Board, part of the Health Education England structure. And we weren't successful in getting all the money we wanted, but we got some. And then the primary care programme through the GP General Practice Resilience Fund gave us some additional funding. And that meant we had enough to really put something in place. So what we did was commission Bradford University to deliver an FCP course for us. And we had 20 fully funded places for the first year available to people who were either in FCP posts or to prepare people to go into the FCP posts as they were created. Now, sadly, our first cohort in our first module got somewhat interrupted by the coronavirus pandemic and the lockdown, but that's now back up and running, and those 20 students will be completing their first module fairly soon and starting the second module in the new calendar year. And we recently had confirmation from our LWAB that they would fund a further 15 places for a second cohort for a second year. So we're really delighted that we've got at least a 2-year plan for throughput. We've still some conversations to have about how we make that sustainable and ongoing for the future, but it's at least a start. So where we're up to is that of our 6 places, the 6 different areas of West Yorkshire and Harrogate, across them we have 52 PCNs. Now we have some of our places, such as Harrogate, where there's 4 PCNs, where all of the PCNs now have an FCP in post. And then we have other places where we have no PCNs in post at all. But across West Yorkshire and Harrogate, about 54% of our PCNs now have an FCP in post. And so that's the NHS England target for this year met. And we're well on the way, we think, that by the time the posts that are vacant and ready, well established and ready to be filled are filled, that we should be well on our way to our 75%, which is obviously next year's target for NHS England. In terms of our service models, we didn't, I won't say we didn't want to be prescriptive, we might have liked to have been prescriptive, but we realised that that wasn't appropriate. PCNs are autonomous, they get to choose to do it the way they want, and it had to be what was right for the system. And we are such a big system that trying to dictate one model probably wasn't appropriate. So what we have is a mix of FCPs that are in services brought in from other providers. We have some that are directly employed by the PCN, and we have some where the FCPs are embedded in the existing MSK service and work in that FCP role in the general practice part the PCN does, but they are employed by the MSK service. So as we went along, we recognised that this is a new role, it is a new way of working, and it is challenging, and to a large extent it can be lonely. So we're in the process of establishing a peer support network. We thought it was important for the clinicians to have clinical peer support, but also to just have that wider workplace peer support of perhaps the more administrative challenges, or just the bit about working on your own. So we've established that, and or we're in the process of establishing that. And importantly, that won't just be for the people who are graduates from the Bradford University programme, that will be for anybody who is working as an FCP in our patch. You would expect that we need to evaluate it. I think we might be at risk of over-evaluation. We are part of the CSP pilot evaluation. Bradford University were already evaluating their programme in terms of how it met their students' needs, but we have asked them to do a wider evaluation of the impact of the introduction of the FCP service on service delivery and provision across the patch. And then we have an insight project which is also underway, somewhat delayed by the coronavirus pandemic as well. We were very fortunate in that we were given a pot of money by NHS England to do some patient insight and to think about how we could do patient insight across a pathway or across a whole ICS, rather than stuff like the FFT or the patient survey programmes, which are all single organisation. And we chose to do it in MSK and with FCP services, so we could really understand what it meant for the patient. We're really trying to pick out those bits where people feel that they get passed from pillar to post and fall through the gaps, and see whether having the FCP part helps at all in any way with integration during the MSK pathway. So it is really an evaluation of our wider pathway, but it will capture that bit about the FCP as well. So I think that's what I have to say, other than to add that, yes, it's taken some of my time, but for the people in the places, the managers such as Claire Ardito in Harrogate, the amount of time that she's had to put into conversations to make this happen, and then to do the contracting and work it all out at place and overcome some of the financial barriers, has been really significant. The bit when the posts were first announced and they were only going to be 70% funded, that was a huge barrier, but in some places we've got that agreement before the 100% funding was announced. The 100% funding for the post has been a game changer, but there are still the kind of wider on costs, the providing a 52-week service that you don't get in 100% of a post. That in some places is still a hurdle that has to be crossed. So
Catherine, am I okay to jump in there just to cut you off? I think that's a perfect opportunity to segue onto our next speaker as you started discussing DES implications. I'm just mindful of time. There's a couple of questions that have come up from your talk on some of the great work we've been doing in West Yorkshire and Harrogate. But I will bring that back to the Q&A at the end if that's okay for the primitive time. Apologies to cut in there. So I have the pleasure now of introducing our last speaker on the panel before we move towards a more open Q&A, and that speaker is Danielle Chulam, who is the Deputy Director of NHS Services within Connect Health, and she will be talking about the DES implications for primary care networks through the lens of FCP. So over to you, DC.
Good afternoon, everyone. So I'm going to jump straight in because, like Larry mentioned, I've got 7 minutes to talk about something that I could probably spend all day talking about. But I do think it is really important that we have an open and transparent conversation about the finances, and that we make every effort to look through the lenses of all of our stakeholders when it comes to aligning the finance and the quality with regard to FCP implementation. So one thing to really note from the get-go is that the DES funding is not a profit generating opportunity. So what I'll be focusing on is the financial stabilisation of the providers and ensuring that we're all being wise with public funding and that we understand the implications and the overhead costs of additional role and service implementation. So can you take me on to the next slide, please, Paul? So let's start by talking about what the DES funding does support, and you'll all be familiar with the 100% funding, but to be within the cap of the £55,560 per whole-time equivalent, the salary ceiling is £44,000 baseline salary plus the on-costs of national insurance and pension. That's with a NHS terms and conditions pension. There is a notable inequity between inner London and outside of London, as the higher cost of living is applied within that same threshold of the 55k. So this means that the baseline salary in London is only funded up to 39,000 plus the on costs. And if we think about how that links in with the work that Amanda presented earlier, then to implement FCP with the DES funding only means that the PCNs and their partners in London may have to be a bit creative with how they employ into these roles, or they will have to be willing to pay the additional salary costs that sit above the DES threshold until such times that this has been reviewed. So I'd personally be interested to see if this has any influential factors with regard to the uptake of FCP in inner London, or if the quality and integration is compromised. So that's what it does include. I'm going to move on to consider all of the overheads that aren't covered by the DES, and Catherine was just starting to step on my toes a little bit there. So we've already spoke about the salary above the DES threshold not being included, but what she mentioned was there was significant initial training need and requirement for ongoing robust governance. And what we get, if we get this right, we can ensure that our clinicians feel supported and that they provide safe and effective care. If we get this wrong, then at best we create a retention issue, and at worst we provide unsafe and ineffective care and potentially further fragment the MSK pathway. So who provides this training, who designs the training, who delivers the training, who quality assures the training, who signs off the clinicians as competent, who supervises them, who mentors them? And I don't have answers to these questions because they will all be very niche to that specific area, but all of this requires resource and time that somebody at somewhere has to pick up the cost for and is not covered by the DES. Move on to liability insurance. So this is not included within the DES, but providers will need to be aware of their current policy and indemnity restrictions. If PCNs employ FCPs directly, then the FCPs will be covered under the clinical negligence scheme. However, if it's a community provider or the trust, then that will need to be taken up with under their current insurance provision. A big thing that I really want to touch on really is line management. So line management, performance management, annual leave management, appraisals, one-to-ones, talent management. A lot of time and resources put into this, and it's not covered. So you would have to have either somebody within the community provider, the trust, or the PCN, whoever's taking responsibility for that clinician. They would need to be additional time and resource. And some dirty maths that I did showed that this to be approximately 2.5k per year per FCP, and that's based on 1.5 hours per week of line management responsibility, and that includes supervision, etc. Then you've got the support functions, so additional HR and payroll resources. And when this is one clinician, you can sort of absorb this, but when we're starting to scale up the FCP and talk about numerous heads, and this requires additional time and resource. I'm not going to go through this list one by one. You sort of get the gist of the overheads, and based on this, it's not unusual for providers to ask for a management fee to deliver first contact clinics. And I think you'll agree, based on some of the overheads listed, that to an extent some of this is not unreasonable. But the question still lies on who should pay for these overheads, and how do we get the balance between evidencing these minimum quality and governance standards within our systems, not being blinded by a freebie option that could put these at risk, whilst also ensuring that these options available are not cost prohibitive to the PCNs. And this is a real wicked problem that we're facing at the moment. You go to the next slide for me, please, Paul. So this slide is a bit wordy and a bit small. We can send this out to you, but this slide is taken from a document that was created by the South Central and West Commissioning Support Unit titled MSK FCP Workforce Mobilisation, and it was released in June this year. So what you can see here at the top are the key benefits of a community or trust provider employed FCP, and at the bottom the same for PCN directly employed. Now, I'll be really honest with you guys, I work for an organisation that delivers FCP services. I sometimes lead on the implementation of that. I'll do my very, very best by you to put my biases aside. But what I will consider is also that there's huge amounts of variation in community MSK delivery and access across the country, and therefore different FCP models may have key benefits in one part of the country, but that same model may be a risk in others. And I think that's something that we just need to be mindful of when looking through the lenses. So I won't go through this slide word for word, but I'll just pick out some real hot spots. So key benefits of community provider or trust employed, taken from this document, is that those clinicians from a community provider or trust have access to profession and speciality specific clinical governance frameworks. They have access to a strong CPD pathway, awareness and visibility of the MSK pathway, experience of working across the whole pathway, and that leads to enhanced referral accuracy and better patient experience. Not my biases, not my words. The risks of that is what we spoke about earlier, is getting that true integration within the PCN team and managing that. And then the management costs. So most providers will be looking for a contribution to cover the overheads. Where they don't, I'd probably challenge the sustainability, quality and scalability of their model. But I won't go any further into that because my biases are creeping in already, aren't they? So the key benefits of PCN directly employed. So the PCNs will get to pick the clinician that they work with and how they embed them within their practices. This document says that they're more likely to feel part of a team. I don't know if that's related to pilots in practices and not an FCP working across 8 different practices. Some of the key risks is the GP time taken away from primary care delivery to supervise, support, appraise, train, mentor, line manage, develop training, sign off competencies. And this has a management cost in itself, and I'm not really sure how the practices will work this out amongst themselves within the PCM. A risk of burnout for colleagues working solely in FCP clinics. We hear this from our GP colleagues regularly. I think it's something we need to be really aware of. Reduction in clinical quality. So this document references minimal visibility to the MSK MDT in the community services and awareness of secondary care pathways that can diminish quality clinically. There are challenges with the provision of appropriate supervision and mentorship that sit within primary care, and risks associated with the management of general employment terms and conditions like sickness and maternity leave. I haven't chucked into the mix because I only had 7 minutes. The challenge of the local private physio clinics and the out of area private providers who are not already within the NHS ICS coming in and gazumping the local system providers, and the benefits and risks around this and around further fragmentation of the MSK pathway. But I did only have 7 minutes, right? So I'll finish with probably a golden ticket question for us all is in how do we collectively ensure that non-DES funded overhead cost management isn't the downfall of FCP quality, scalability and longevity? And I'll leave this all for us to reflect on, but it might start to trigger some of the questions that come my way. So thank you.
Thanks, Danielle. Really nice insight there regarding the DES funding. A couple of questions in the chat which I might group together, and you alluded to this previously, in that FCPs, the DES funding covering off 100% of the FCP role, and what the PCNs then hear is it's a 100% funded. Is this your experience in terms of conversations with various PCNs, and what do you foresee as some of the risks or unintended consequences that you started to allude to? You've got 2 minutes to answer.
Definitely. So I've had conversations with many business partners, clinical directors from across the country, and I think it's been a little bit overwhelming for them. You know, it's not just FCP that they're implementing, so they're trying to get their head around PCN's development and all of the additional roles. So to hear it's 100% funded, it felt like a dream, but not really considering all of those overheads and additional implications. Some of them have different perceptions on how their own personal biases and their own model may impact the system. So they didn't want to destabilise the community services. They thought that direct employment might be the answer to that, when actually it's probably swings and roundabouts and a bit of both, depending on the circumstances. I definitely think that the overheads and the time and resource of implementation and ongoing management and leadership within this has not probably been considered in detail by the people that I've had conversations with anyway. It's been a bit eye-opening when they start to understand all of the work that goes alongside making this successful.
Brilliant, DC. Thank you very much. So I'm going to open up the Q&A to the wider panel now, and just a bit of a reminder, we're looking to finish the webinar today at 1:45, so we've just got under 20 minutes to really put some tricky and tough questions to the panel, I hope. And I mentioned that I'd acknowledge Martin's question in the chat, and it's the most liked. So I'm going to ask this question, but also add a little bit of a slant to it to bring another question as well. And I'm going to start with Catherine once I've asked it. So having discussed ICS plans for 100% coverage of the system with PCNs per primary care network, there may be a risk of quantity over quality. And linking that into Martin's question, the first part of that is, how do we ensure quality going forward? And also, there are a large number of people that have already entered these roles prior to the roadmap that Amanda and the team at HEE have produced, at being employed at band 5 and band 6 level, and often employed directly either by the GP practice or by a private provider that may be out of area and moved in. So where do we stand from that risk perspective of how do we ensure quality? And the second part of that is, how do we mitigate the risk of quantity over quality?
So I think the second part of that question is easier to answer than the first, and Danielle will correct me if I'm wrong, but my understanding of the DES funding is that it can only be used against band 7 and 8A posts. So if somebody is employed who is band 5 or band 6, the funding can't be used against their post. So that bit is actually technically easier, particularly if you're saying that largely these tend to be direct employed people. The bit about how do we quality assure, because, you know, even if you employ a band 7 person, just being band 7 doesn't guarantee quality. And I think that the only thing I can say is that that's been about relationship building and the contracting negotiations about what is the expectation, and in some of our places that's been more successful than others, that the sort of MSK service providers who are largely the deliverer or have been very influential in establishing our MSK provision have been very clear about the added benefit of having it integrated into an MSK pathway, that they can do the quality assurance. And we've also tried to, well, we've beyond tried, we have agreed our ICS-wide expectations. The difficulty is that if there is a PCN that wants to direct employ, we have no authority. It is only through influencing and relationship building. We can't mandate.
Okay, so can I jump in? I can answer the part two of that really. So in terms of the ones that are already existing in the system, whatever band they are, or everybody who's already sitting in an FCP role will be expected through guided supervision to do the training anyway. So we have created a standard of practice for the first time in primary care. It's never happened before. So if you created a standard going forwards, then you need to make sure the standard works going backwards as well. So there, in the roadmap document that's coming out in October, it's very clear that this needs to happen. Although it's not a penal thing, I have to say, but what it does mean is that if they're not signed off against the low skills, and actually they haven't done the FCP portfolio route training or an FCP course to make sure that they have done that training, then they will not be able to go on the directory as an FCP at the Centre of Advancing Practice. So I would suggest that is the way that we're going to make sure that the standard's correct going through. And you're absolutely right, people, they can't get their funding unless they prove the capability of that clinician moving in. So moving forward, we're in talks with CQC, and CQC are going to become the external governors for these roles, and they will become part of the inspection to make sure that they have been signed off or have been trained to that level of practice for both the Band 7s and the Band 8As. So there's implications around advanced practitioners as well. That advanced practitioners need to either have done an ACP master's degree, so we know that they're working at level 7 across all 4 pillars of practice, or on the portfolio route from the Centre of Advancing Practice to make sure that they're verified to level 7 across all 4 pillars of practice, and the CQC will be asking for that information when they come around in the future.
Brilliant, thank you very much, Ryan. Just to follow up on that, so again some questions from the Q&A on the side. So there's lots of questions around governance and the pathway implementation, and I can see one of the responses from Amanda to somebody querying about their background in sport, and I think it kind of loops back to the original first question of the day regarding the 3 years qualification rather than competency based. And if somebody was working in sport, they might have experience with acute care, acute injuries, so on and so forth. Does that count towards their 3 years experience prior to stage 1? I suppose one of the questions that keeps coming up, or points that keeps coming up, is around this undifferentiated condition aspect of things. And from a kind of from smaller private providers that may be moving into certain areas where they've worked with patients that are traditionally within a self-referral model. And I think John alluded to potentially these physios not having the competence to work with undifferentiated conditions. Does there seem to be a steer towards trying to promote the use of the existing MSK provider and creating service level agreements between that MSK provider and the PCNs? And I can just see I've lost the chat. I think it was Julie that asked that final question regarding promoting the SLA. So can I give that question to John to begin with from a GP commissioner perspective?
Sure, I can't speak for the other hundreds of PCNs around the country. The two that I've been involved with, South Tyneside and the one I'm now involved with in Manchester, we are certainly favouring looking towards developing SLAs with existing provider organisations rather than directly recruiting and employing individuals. And I would say there is a preference to working with organisations that are already part of the health and care system, so that we are assured that they understand what the system currently looks like, and we could have better seamless, unfragmented pathways from person in their own home, potentially through an FCP, and then if necessary to community physiotherapy or orthopedics, podiatry, etc.
Brilliant, John. And I'll just following up on that, John, and I think this question either to yourself or Amanda or Danielle, I think it probably best focuses. There's been a few people reflecting in the Q&A that they're finding it quite difficult to implement FCP within the existing MSK pathway. And if there's a general feel within the chat that that is the preferred direction that we should be supporting, John, I'll ask you just to reflect first, and if I can then bring Danielle and Amanda in. From implementing FCP within the existing MSK pathway, what lessons are there that you may be able to share whereby you can successfully implement FCP without necessarily destabilising the existing MSK pathway? So John, you have to come back on that first.
Yeah, sure. Yeah, but I don't think it should. I don't see why it should destabilise the existing pathway, other than if there's a shortage of physiotherapists and you're effectively robbing them from one part of the system to rebrand them as something different in the same system. It should complement the pathway, really. Most GPs don't have high confidence in managing MSK conditions and will often do the wrong investigations and refer to the wrong people. So introducing FCPs into general practice should actually make sure that the patients who either go to community physiotherapy, orthopedics, podiatry, rheumatology, pain services, etc., are referred with the right investigations at the most appropriate time. So I think it would make the pathways better, not worse.
Brilliant, thank you, John. And I always remember at the Big R's there was a FCP from Scotland reflecting that within their department all the band 6s and band 7s appeared to be shifted out and put into primary care, and there was nobody there to develop the less experienced 6s and 5s. So Danielle, can I come to you to comment on that?
Yeah, no, I'm probably mindful of not just looking through tunnel vision at services that I'm familiar with, and being aware that actually the MSK landscape is very different in different areas, and for some areas where they've got a great access and good integrated MSK service, self-referral routes, etc., then I would see there be massive risk to probably put in another provider in the mix. Where there is any qualified provider type models, when there's already a fragmented pathway, then this could actually add benefits as bringing in another provider from the patch. So I think it probably needs to be really specific to that current landscape, and we know that there's massive variation across the country with regards to that. But I would probably and as Amanda mentioned, there will be some NHSE guidelines coming out around integration within the current integrated MSK pathways, which I think is really positive, but we recognise that it's not always rosy in each area.
Brilliant, thanks DC. I can just see a few people commenting in the Q&A reflecting on the similar experiences of seeing their 6s and 7s moving out the department. Larry, do you want to come in off the back of that?
I do, and I think it's a really important question, Andrew, but I also think there's a really important aspect of recognizing what happens when you implement any large-scale change. You're going to get some variation of that change in that model, which part of the reason, I think someone asked the question, why is the CSB so invested in this model, is partly to protect our colleagues and members, but also to ensure that implementation is effective and to try and support that, because we recognize it's complex and you need those resources from multiple angles. I think simply to answer the question is, I don't see, so this comes up a lot, and I think the idea of destabilization, I'm not sure it's embedded in facts or evidence necessarily. So yes, I think the example used in Scotland was a good one, because that has happened, but I think Scotland has a completely different health system in terms of the centrality of how they commission their services, which is different to how we do things in England. But I think essentially the answer to that question is that this is complex, and therefore you need those things I talked about at the beginning. You need that systems leadership. You need people like Catherine who are going to facilitate and bring all those key stakeholders together. You need people to be able to understand the needs of their population, and to be honest, we have to step away from MSK sometimes to understand the bigger impact. So and sometimes that might not be necessarily, I don't necessarily think it will destabilize MSK at all, potentially if things are done effectively, but also there's a real opportunity for these roles to massively reduce GP capacity, or rather increase GP capacity to focus on some of the other priorities that they need to. So GPs are never not going to have enough work to do. It's just that actually we might be able to take some of that work which we can focus on and have that specialty to support and manage, whilst enabling the rest of the wider healthcare system to effectively function and work. And in theory, if these roles are working effectively and having the impact, we should see a little bit of a reduction in demand into other stages, and even if not reduction in demand, then at least that higher conversion rate that John touched on. Part of the conversation we're having, Ashley, and I know would continue, is around actually there's this cap on FCPs, which is partly there most likely because of the worry around destabilization and having too many people move over. But eventually, I think there's going to have to be a question of taking that cap away and really thinking about what does this population need in order to make sure that these roles work for primary care, but also for the rest of the system. And part of that obviously then links in again with workforce education and all those other things. So it's very complex, but basically requires leadership and relationship. External stakeholders like the CSP, HEE and NHSD can do that, but there's also a responsibility for us as members and clinicians to take that forward.
Brilliant, thank you, Larry. I think it's probably a good time to bring Catherine in on that, because when you mentioned around systems leadership.
So thank you, Andrew. I just have 2 points on that, really. I think Larry's point about this being more fear than actuality about the destabilization of pathways is the reality, because it was one of the first things that we were challenged with when there weren't any examples of, it will destabilize our services. Well, there aren't any examples of that happening because it isn't happening anywhere. I do wonder whether there is also some risk, that if it is a different provider, so we have a new provider coming in doing the FCP part, we can reasonably expect, I think, that there will be at least some fall off in referrals into Tier 1 MSK services, and if that happens, well, it depends on how they're funded, doesn't it? There may be a real risk to some of the people who don't then end up providing this service, and it's just about understanding how it fits in your system. And I think that's the importance of having, when I say whole system, I don't necessarily mean like the whole of my ICS, because that's huge, but a whole place-based view of what's best for that place in terms of the model of delivering. But one of the things I wanted to come back on was that thing about not enough support for the band 5s and band 6s. One of our places has a model where it is the existing MSK service that delivers the FCP service. None of those FCPs work full time as an FCP. All of them come back into the department and are doing part of the normal MSK service. Some of that was to safeguard the training and development of people in the existing department, but some of that was to protect the individual FCPs so that they're not on their own working as a single-handed practitioner all day, every day, and that they had some job variety as well and were able to maintain some of their other clinical skills. Because if you just did FCP all day, every day for a lot of years, you could become quite de-skilled in other areas and limit your own career progression. So I just think there's ups and downs to any of the models, and you need to find what's best for your own place.
Brilliant, thank you, Kat. I'm mindful of time, and I suspect we're going to run over by a minute, because I'm going to ask one final question to all speakers to provide their closing comments. But I just wanted to say thank you first and foremost to the people that have attended the webinar. I think that the volume of questions, 83 questions in just over an hour, does really kind of demonstrate how much of a hot topic this is, and the diversity of the questions and how direct and how challenging some of the questions have been. It really made the webinar what it is. So thank you for your engagement. The question I'm going to have to the panel, and I'm going to go left to right based upon the pictures on the screen rather than cameras. So I'm going to start with Amanda, then Larry, then John, then Catherine, and then Danielle. Each of you in turn, if you could give one bit of advice to those on the call with regard to what is crucial for the successful and sustainable implementation of FCP, what would it be?
Who's first?
You, Amanda.
Hey. Okay, so the most important thing, this is for me and from my perspective, is to remember that It's the patient that is at the centre of this. So whatever you decide to do for implementation, it has to be to the benefit of the patient. That's what we're trying to do, is create gold standard care. So I just, anything that you're thinking about, based on your decision, if it gets tricky out there, I want you to come back and think about the patient that's in the middle, please.
Thanks, Amanda. And over to you, Larry.
So for me, it's not going to be one thing, I'm just going to be three things. So firstly, you have to understand your stakeholders, and back to what Catherine said, understand your place in your system. That's fundamental, and what the specific challenges that are there and what you can bring to it. It's also about understanding the rationale for these roles. So sometimes that takes a bit of stepping outside of our own little bubble and understanding the bigger picture, and actually what are we trying to achieve with these new roles, because these roles are here to stay. They are not going anywhere. These are national priorities, and it's taken a long time to kind of bring everyone together. Primary care, GPs, the BMA, you know, these roles are really important going forward, and it will go beyond physiotherapy and have additional roles in those areas as well, and they will grow. I guess finally, in terms of the physios on the call, and even actually, to be fair, the PCNs as well. So we have a whole resource and a whole team to kind of support implementation. So please reach out. We're here to help. Sometimes it might be putting you in contact with people who we're in contact with in your local area. Sometimes it might be providing you additional resources, or perhaps some coaching or helping with conversations. So do reach out to the kind of support structures that there are. And I know Amanda's quite approachable as well. So yeah, so reach out if you need some help dealing with specific challenging issues.
Brilliant, thank you, Larry. And over to you, John.
I would say start small, evaluate, learn fast, and be prepared to change.
The key principles of anything quality improvement related, John. Thank you very much. And Catherine, over to you.
A similar message, really. It's about change. So understand what's right for your place. Keep talking, and remember to see something from somebody else's perspective. So understand the fears of the other side, as it were, and all of the different stakeholders, and you'll be able to find a position that works for everybody in the end.
Brilliant, thank you, Catherine. And last but not least, Danielle.
I'll probably go back to the plea. I'm completely in agreement with Amanda's point around making sure that the patient's at the heart, and the patient experience and journeys and outcomes are not compromised, and in fact enhanced. But largely around, my plea would be to not let the finances dictate the pathway and the implementation. Let's try and collaborate on that rather than be competitive and play a tug of war against finances would be my plea.
Brilliant. Thanks, Stacey. It brings us full circle, doesn't it, to Amanda's point about thinking about the patient, so moving beyond costs and thinking about value added. So thank you very much, guys. Then we've got one more slide left, if you can move on to the final slide. Which is just to shamelessly plug the next in the series of these webinars. So it takes a slightly different focus, but the next webinar is next month, the 21st of October. We're going to start it early in the morning, so hopefully with a nice coffee. And it's titled Chronic Pain, Myths, Misconceptions, Misinformation, and Why Changing Understanding is the Key to Improving Lives. So without further ado, I'm going to end the webinar there. Thank you very much again for all of the panel for giving up their time and presenting today and taking your questions. And thank you to each of you for attending and making the webinar what it is. So thank you, and look forward to seeing you on our next webinar on the 21st of October. Thank you very much.